Thank you for the introduction. As you've heard, my professional career was in high-risk obstetrics until the middle of last year. And since then, I've been also quite heavily involved in medical legal work. And there's nothing which is could be said to be any more central to what I did, both as in terms of my profession and also in terms of what I now do, than this whole question of assessing fetal well-being. And to put this in context and to look for a point to begin, we need to go back to 1968, which is just 54 years ago. At this stage, Hewlett-Packard released the first commercial cardiotocograph machine. So cardiotographs have not been around for all that long, and it's a technology which we are increasingly coming to grips with, and something that is a very useful tool in the management of all obstetric patients. Now, I'm sure the audience to whom I'm talking now, although I don't know exactly who you are, you will all mostly trained in some aspect of obstetrics, and that you will all know the basics. And that's true for all of us. And I'm not going to go through the exact basics of fetal monitoring today, but what I hope to do is to provide some greater degree of conceptual clarity around difficult issues. And I want to appeal to the need to establish more rigor in terms of the way in which CTG tracings get interpreted. Because that is, if anything, the thing that we lack most of all. And I'm speaking not only for you here, but for myself as well. We're all very au fait with walking through a labor ward and glancing at a CTG tracing of a patient who's in labor and thinking that it's okay, or seeing the decelerations and thinking they're not significant, without really stopping and to examine the tracing carefully. And that is the beginnings of the errors that we often make. So I want to unpack to some extent the classifications that are used in reaching a diagnosis when assessing tracings during labor, and point to what we need to do in accordance with international recommendations when it comes to the management of abnormal tracings. Now, at the outset, I need to say that you need to distinguish clearly between tracings that are performed and made firstly prior to the onset of labor, and those that are made during the course of the labor. And when we're looking at antenatal tracings before the onset of labor, antepartum tracings, we are really concerned with the question of the cortical control of the fetal heart rate. And by that, I mean to say that during the antenatal period, activity in the fetal cerebral cortex is a determinant of whether the tracing changes by means of an acceleration. And the physiology that you need to understand is that the cortical area of the brain, the fetal brain, that controls the fetal heart rate lies in juxtaposition to that which controls fetal movement. And fetal movements and fetal heart rate activity are linked. That if the baby moves, then you're usually going to see an acceleration in the fetal heart rate. And such tracings are usually referred to as non-stress tests, NSTs. And I know that in some parts of the country, there's a tendency to even describe intrapartum tracings as NSTs. Now, that is incorrect. It's simply based on a misunderstanding. NST stands for non-stress test. And we got to this terminology because years ago, there was a tendency among certain people to try and assess fetal placental reserve before the onset of labor by setting up an oxytocin infusion, making the uterus contract, and seeing whether or not there was any change in the fetal heart rate pattern. So that was a CST, and what we've now been left with, that luckily the CST is gone. Nobody does that anymore. But we're left with this term NST, which is a non-stress test. So the thrust of this is that in the antenatal period, we're looking for a cortically mediated acceleration of the fetal heart rate as a manifestation of normal fetal cerebral cortical function and normal fetal well-being. And in this regard, it also has correlates with what we do when we do a biophysical profile, where we're looking for other cortically mediated responses in the fetus to ascertain whether or not the fetus has a normally oxygenated and a normally functional cerebral cortex. Now, when we do these tracings, they are influenced by several factors that need to be technically correctly done. In other words, we need to position the mother on her side and not on her back to ensure that there's optimal placental perfusion. We need to take into consideration maturational effects, acknowledging the fact that the sinoatrial node, which plays a role obviously in the control of fetal heart rate, only matures at about 26 weeks. And that is then followed progressively with maturation of the parasympathetic nervous system, which is responsible for the introduction of fetal heart rate variability. And then finally, what happens is that the reticular activating system in the fetal brain develops, and beyond a certain point, beyond 32 to 34 weeks, it exerts its effect on the fetal cortex and gives rise to discrete states of fetal arousal, which can be clearly characterized. So in other words, whether the baby is awake or asleep. And these various states of fetal arousal were first characterized by somebody called Nijus, N-I-J-U-I-S, Nijus. And of the original states that he described, we now only really recognize 3 states, 1F, 2F, and 4F. And I want to just spend a moment describing what these are. 1F is a baby that's quietly asleep. And under these circumstances, when we look at the characteristics of the tracing, we'll find the baselines in the normal range, the variability of the tracing, the extent to which it bounces around, if you like, in terms of its bandwidth. It's less than 7.5 beats per minute, and there are no accelerations and no movements evident during this period of quiet sleep. And this is, if you want, for want of a better description, what I would call it the dead to the world fetus. It's fast asleep. On the other hand, you may have a baby that is asleep, but nevertheless active. And I've just termed this the sleepwalking baby. And this is a baby that shows fairly frequent gross body movement. And the effect of this on the CTG is that there are now accelerations evident paired with the fetal movements that are taking place. And these are more than 15 beats per minute, lasting more than 15 seconds. And as I say, there's movement evident in the baby. Variability is also increased in this state to 7.5 beats per minute with a standard deviation of 15 beats per minute. And this needs to be contrasted then with a baby which is actively awake. And the actively awake baby is the restless child, if you like, the jogging fetus, one who's showing vigorous activity with many trunk rotations, and it has an essentially unstable fetal heart rate characterized by large and long-lasting accelerations, which can even be fused into one another to look like a sustained tachycardia. And the characteristics we see is that the baseline might appear to be more than 160. There's a lot of variability in the tracing, more than 15 beats per minute, more than 30 beats per minute, lasting more than 30 seconds. Those are the accelerations, and there's lots of movement. Now, I raise this as an issue because you must be careful when you're looking at a non-stress test in an antenatal patient not to see the tachycardia and mistake it for an abnormality of the tracing, whereas in fact it may simply represent a baby that's actively awake and moving a lot. So these cortical events vary over gestational age. So less than 32 weeks, most of the babies are asleep. 58% of them are in quiet sleep. But as you get beyond 32 weeks, the predominant state is that they've been actively asleep, and that is about 65% of the babies show signs of being actively asleep. So be aware of the sleep cycles, be aware of the fact that an active awake baby with a prolonged accelerations, it's not a baseline tachycardia, but simply a reflection of a physiological state. And the clue here is that there are lots and lots of movements. Now, how do we use non-stress tests? And here I need to be also very explicit in saying that an abnormal non-stress test simply indicates an absence of normality. And in this sense, it differs from an intrapartum tracing, because intrapartum tracings, when they are abnormal, they're very clearly linked to imminent fetal jeopardy. The baby is becoming hypoxic, and if you don't do something, there's a risk of long-term damage. But that's not true of the NST. The NST simply indicates an absence of normality. And having said that, if it's repeatedly abnormal, it's not to be disregarded, and it requires some kind of intervention. And that's particularly so where it's used in the context of high-risk pregnancies, which is where we do use it. So post-dates pregnancies, preeclamptic mothers, diabetics, babies that are growth restricted, mothers who've had antepartum hemorrhage. These are the kind of circumstances where we wish to interrogate fetal well-being in the context of cortical activity. And if it's persistently abnormal, it may be an indication for intervention and delivery. So I just need to read this to you. This just simply underlines this point, and it comes from Umano, who points out that no trial has conclusively proven that antenatal testing lowers the risk of long-term adverse outcome. And whatever recommendations exist in the literature with regard to the validity of NST tracings must have a rating level which rests at the point of consensus and expert opinion, but not on the basis of any clear evidence that they make any difference to long-term outcomes. So I want to park that to one side now. That's the antepartum tracings, and I want to talk now about intrapartum tracings, because this is really, if you like, the guts of what we need to talk about. It's really the important stuff. And here, when we look at intrapartum tracings, we're no longer now concerned about a cortically determined effect on the fetal heart rate pattern, but things that have to do with autonomic reflexes. And again, one needs to take a step back and one needs to just think for a moment about what labor actually does to the fetus. And labor and the process of vaginal childbirth is, for any of us, the single most dangerous journey that any of us will undertake in our lives. And the reason for that is that that uterus is contracting, and as it contracts, it's repetitively cutting off the oxygen supply to the fetus and exposing the fetus to the risk of hypoxia. And hypoxic fetuses end up with long-term neurological injury in the form of cerebral palsy. Now, again, exactly why these seminars take place is because we have a problem. And cerebral palsy rates related to intrapartum events in the developed world, in other words, industrialized countries with lots of resources, sits at about 10% of all cases of cerebral palsy. But in South Africa, 38% of the cases of cerebral palsy can be related to things that happen intrapartum. And these are generally things that are avoidable causes for neurological injury. And that's data that comes from a pediatric neurologist at Stellenbosch, Professor Ronald van Toorn. And arising from this, obviously, there's the human tragedy of children that are damaged. And there are lots of also implications, obviously, for us, the healthcare workers. When we're involved with a case where there's been this kind of adverse outcome, there's a psychological price to pay, and then there's legal and financial prices that arise as well, directly as a result of this. Now, again, I'm talking, I'm sure, to the educated here that you don't need to have me point this out, but I'm going to anyway, that the structure of the placenta is that it's attached to the side of the uterus, the decidua over here. Between the decidua and the placental plate here is an area which is a virtual lake, which is the choriodecidual space. And blood supply from the mother comes back down through the myometrium, through the decidua, through these spiral arteries, and it gets pumped into this choriodecidual space over here. And floating in this choriodecidual space, much like the fronds of a seaweed, are the villi, the placental villi, through which the baby is pumping blood. So the gas exchange is taking place here from the maternal blood across the wall of this villus into the fetal circulation and going back through the umbilical vein into the baby to keep the baby oxygenated. And the problem in labor is that as the uterus contracts, as the fibers of this myometrium interdigitate, what they do is that they squeeze these spiral arteries that are coming in to feed blood into the placental bed. So for the duration of a contraction, you are interrupting the supply of maternal oxygenated blood to the choriodecidual space, and the baby, for the duration of the contraction, needs to survive on what oxygen is available in the blood that's trapped in this choriodecidual space during the contraction. And that has measurable consequences. And here's very old research. It comes from 1995, McNamara, published in the British Journal of Obstetrics and Gynecology, showing what happens to the fetal oxygen saturation in relationship to the contraction. So the contraction in the heavy bar comes along here, it goes up and it comes down, and the change in the fetal oxygen saturation is a drop towards the end of the contraction of between 5 and 10% in the fetal oxygenation. And that's happening because of this contraction that's taken place. And ladies and gentlemen, it underscores why the guideline recommendations, if you're going to auscultate the fetal heart rate during labor, has to be done before and after the contractions. And if there's any slowing of the fetal heart rate after the contraction, you need to consider the fact that the baby might be becoming hypoxic as a result of the process of labor. Now, I've suggested to you that labor is a singularly dangerous time, and indeed it is. And it is a hypoxic stress to the fetus. And throughout the labor, there's a drift down towards fetal hypoxia. And again, here's research done many years ago now, looking at oxygen saturation in the fetus in early labor, showing that it's about 68%. And by the time you get to the end of the first stage of labor, it's down to 58% on average. So if the baby has contractions, or is, if you like, in an environment where there are too many contractions occurring too frequently, or the contractions last too long, this process of becoming hypoxic may become exaggerated, and there may be an increase in fetal hypoxia, which may preclude the process of aerobic metabolism. And the baby may then switch over to anaerobic metabolism with an accumulation of lactic acid in the circulation. And the baby therefore becomes hypoxic and acidotic. And when that happens beyond a certain threshold, it triggers in the fetus a autonomic response that involves both the chemoreceptors and the baroreceptors, and it leads to an autonomically mediated change in the fetal heart rate pattern. And obviously, hypoxia, if it's severe enough, can also directly affect the fetal myocardium. So, ladies and gentlemen, what we're looking at in labor is different to what we're looking at in the NST. The NST is the cortex functioning normally, and during labor, we're asking the question, is there any evidence of autonomic changes having an effect on the fetal heart rate, yes or no? Now, when we talk about CTGs, there's immediately this polemic that comes to the fore. And the polemic says that actually these CTGs are not helpful. They have a poor predictive value, and they don't prevent CP, cerebral palsy. And to some extent, this is true, but it's not the whole story. And to unpack this, I think what you need to understand is that cerebral palsy as an endpoint represents many different conditions, and in industrialized countries, only 10% of those are due to intrapartum events. But neonatal encephalopathy of early onset is a different matter altogether. It is the link, if you like, between intrapartum hypoxia and the possibility of cerebral palsy. But it's a more proximate link, and it's actually a more proximal marker of intrapartum hypoxia. And what evidence there is in terms of favoring CTGs demonstrates exactly that they do reduce the risk of neonatal encephalopathy of early onset. And many of you will be familiar with the Dublin trial, which was a 13,000 women randomized to continuous electronic fetal heart rate monitoring versus intermittent auscultation. And what that trial showed was that there was a reduction in seizure activity amongst those who had the electronic monitoring. So yes, there is evidence that the most proximate marker of intrapartum hypoxia, early onset neonatal encephalopathy, is beneficially reduced where electronic monitoring is used. I might add that there's no study ever been conducted in fetal heart rate monitoring versus no monitoring at all, because that would be simply unethical. And even in the absence of what we might be considered to be a sufficient evidence base for what we do, nobody is going to go and do that study simply because nobody's in equipoise about whether or not fetal heart rate monitoring is useful. Now, regardless of how we want to think about abnormal tracings, one thing that we can be certain of is that if hypoxia and acidosis as an outcome measure in a delivered baby has not been documented shortly after a normal tracing, normal CTG tracing has been recorded. So if you have a normal tracing, you are not going to have an adverse outcome. But the operative word here is shortly before that. And this is an opinion which has been written into one of the most important recent contributions to the subject of fetal monitoring by the International Federation of Obstetricians and Gynecologists, who in 2015 produced a consensus statement about intrapartum monitoring that has been published. And this is verbatim what comes from that particular document. I'm just trying to get rid of something that's in the corner of my picture here. Sorry, I'm going to go back. So what they've written is that, on the other hand, suspicious and pathological tracings have a limited capacity to predict metabolic acidosis. And in a large percentage of cases with suspicious and pathological tracings, they do not have adverse outcomes. So what FIGO is saying is that an acidotic, hypoxic baby will always have an abnormal tracing. So the abnormal tracings, if the baby is hypoxic and acidotic, the tracing will be abnormal. And that's the issue of sensitivity. So CTGs, abnormal CTGs, are a sensitive marker of the acidotic hypoxic baby. However, an abnormal tracing, out of all the abnormal tracings we see, only a few are going to be attributable to hypoxia and acidosis. And this is the issue of specificity. So I want to bring it back to the fact that what we are saying is that the tracings, the CTG tracings, are a sensitive but non-specific marker of fetal hypoxia. Now, having said all that and having dealt with this issue of the fact that CTG tracings have a role to play, I want to move on and talk now about the actual process of analyzing CTGs. And here again, I want to draw your attention to the fact that the devil lies in the detail. You need to understand what's written in the various classifications in detail. Whichever one you're going to use, you need to understand what's been written there and apply it rigorously to any tracing that you're analyzing. And there are various authoritative bodies that have made pronouncements in this regard, and they include FIGO, the NICE guidelines, ACOG, American College of Obstetricians and Gynecologists, and they all tend to divide the tracings up into those that are normal, where there's no evidence of hypoxia, those which are suspicious, where there's a low probability of hypoxia. And please read into this, low doesn't mean no probability, it means a low probability of hypoxia, and those that are pathological, where there's a high risk, high probability that the baby is going to be hypoxic and acidotic. The ACOG crowd don't talk about normal, suspicious, and pathological. They talk about category 1, 2, and 3. And I know for some reason or other at the University of Witwatersrand, this is their preferred classification in contrast to much of the rest of the country. I'm just putting it in there. So for those of you who've trained there, you will know that I haven't forgotten about you. But what I would like to do is I would like to suggest to you that perhaps the most useful classification to know in detail is the most recent one, which is the FIGO classification, because the degree of specification in the FIGO classification is less than in the others. It's easier to remember, it's easier to use in the clinical environment. And I'm going to start by just unpacking a few things that we need to look at when we analyze the tracing. And I'm going to begin with the baseline. And the tachycardia, for example, is a baseline value above 160 beats per minute lasting for more than 10 minutes. And throughout all these classifications, you will see there's specification of a threshold, more than 160, and a duration, more than 10 minutes. So tachycardia is 160 for more than 10 minutes. And again, we know what the common causes for this are. It may be that the mother's got a temperature, either because she has an infection or because she's had an epidural, or the baby might be in an infected intrauterine environment, for example, or the mother might have been given drugs such as beta-adrenergic drugs to stop preterm labor. These can all cause the fetal tachycardia. But the small print that I want you to be aware of is that in the initial stages of non-acute fetal hypoxemia, catecholamine secretion may also result in tachycardia. So where you see a tachycardia during labor, you cannot simply write it off. You need to consider that tachycardia and make sure that you're not dealing with a baby that has become hypoxic already. At the other end of the scale, bradycardia is a baseline value below 110 lasting for more than 10 minutes. And again, this comes from the FIGO document. They say they concede the fact that values between 100 and 110 can occur in normal fetuses, especially in post-stage pregnancies, and then maternal hypothermia, beta blockers, fetal arrhythmias can all cause a bradycardia. But in general, we would also think of a bradycardia as being indicative of hypoxia, and very often severe hypoxia as a pre-terminal event. And in this context, there's a more recent publication, it's either 2020 or 2021 by Peter Baxter, looking at markers of perinatal hypoxia, ischemia, and neurological outcome and assessing the impact of insult duration. And what Baxter did was he looked at babies that had a persistent fetal bradycardia immediately prior to delivery. And what he showed was that it only takes 11 to 20 minutes of a persistent fetal bradycardia for the baby, for 1 in 4 babies, to sustain evidence of an injury, hypoxic injury. And after 20 minutes, 85% of babies will have evidence of a neurological injury. And the nature of that injury is going to be severe impairment in most cases. So bradycardia, when you see it, you do not have a lot of time to react, to get together and to consider the process of resuscitation and to do something about getting the baby delivered. Very short time before there's evidence of injury. The next thing that we look at in tracings is to do with variability. In other words, whether the tracing bounces around on the baseline or whether it's a flatter tracing. And here again, there's a definition of a threshold. So it's normally above 5 beats per minute. And if it's less than 5 beats per minute, it's reduced variability. And there's a time mentioned here again, which is 50 minutes in the baseline segments and 3 minutes during decelerations. Now, again, why during decelerations? Well, frequently you will see variable decelerations during labor. And the characteristic of variable deceleration is that there's an abrupt onset, variability in the trough of the deceleration, and then an abrupt recovery. And it's that portion of the deceleration that they're talking about when they say that if there's more than 3 minutes of reduced variability in the trough of that deceleration, that is indicative of reduced variability as a feature of an abnormal tracing. Now, we know that, for example, prematurity, hypoxia are important causes of a flat tracing. We also know that the baby that's asleep or the baby that's been drugged with narcotic analgesics given to the mother may have a flat tracing. But to that, we also need to consider whether or not there's evidence of intrauterine infection, which can also cause a flat tracing, and whether there's not perhaps evidence of a previous neurological injury. These are all factors that are known to be associated with a flat tracing. But here there's an important caveat added by the people who wrote the FIGO guidelines saying, following an initially normal CTG, reduced variability due to hypoxia is very unlikely to occur during labor without preceding or concomitant decelerations and a rise in the baseline. In other words, this is not usually an isolated finding if it's indicative of hypoxia. At the other end of the spectrum, you may also have an increased rate of variability. So this is what we call a saltatory pattern. And the bandwidth value exceeds 25 beats per minute. So it's gone from 5 to 10 up to 25 beats per minute. So there's a threshold and there's a time limit, which is 30 minutes. And we don't really understand why this pattern develops, but it seems to do so under circumstances of acute, rapidly evolving fetal hypoxia and acidosis. And it's thought to represent some kind of autonomic instability in the fetus. And it's usually linked, if it's due to hypoxia, to decelerations on the tracing as well. So we've covered the baseline, we've covered the variability. The next thing we need to consider is the question of decelerations. And again, late decelerations, that's defined here in this text, a gradual onset and or gradual return to the baseline, and or reduced variability within the deceleration. But then they also tell you what a gradual onset and a gradual return to the baseline means. So the baseline carries along, and then there's a gradual descent into the trough of the deceleration. If it's longer than 30 seconds, which is not very long, from the point that it leaves the baseline down to the trough of the deceleration, and takes longer than 30 seconds to go from the trough of the deceleration back to the baseline, then it's a prolonged onset and return, which is characteristic of a late deceleration. And they also add here that when contractions are adequately monitored, late decelerations start more than 20 seconds after the onset of the contraction and have a nadir after the acme of the contraction, after the peak of the contraction, and they return to the baseline after the end of the contraction. So there's a description here of what a late deceleration is. And I repeat, we are so much inclined to walk past a tracing, look at it, eyeball the decelerations, and have an intuitive feeling of what they represent without actually stopping and applying these criteria deliberately and carefully to decide whether or not the decelerations are significant. There's also another important caveat here, and that we generally say that an acceleration or deceleration is only defined by the deviation of the fetal heart rate by 15 beats per minute or more from the baseline, either upwards or downwards. But if you are looking at decelerations and there's reduced variability, even a shallow deceleration with an amplitude of 10 to 15 beats per minute becomes significant. So you can't necessarily also write off shallow decelerations because they are less than 15 beats per minute in amplitude. You have to look at them more carefully than that. Now, the most frequent decelerations that you're going to see during the course of a labor are variable decelerations. And these are decelerations with a rapid drop from the onset to the nadir in less than 30 seconds, good variability within the deceleration, and a rapid recovery to the baseline, which vary. The morphology of each deceleration varies in relationship to one another, and also in the temporal relationship to the contractions that provoke them. In other words, they don't look quite the same, although the general structure of each deceleration is the same. They are the majority of the decelerations you see in labor, and they reflect a baroreceptor-mediated response to increased intra-arterial pressure in the fetus, such as may be caused by umbilical cord compression. And on their own, they are seldom associated with any important fetal hypoxia and acidosis, unless they've evolved to exhibit other features. So if they change, if they become more U-shaped, if there's a prolonged onset, prolonged recovery, if there's loss of variability within the deceleration, or if their individual duration exceeds 3 minutes. There you go. Threshold and time all comes into all of this. If it exceeds 3 minutes, these are not simple, uncomplicated variable decelerations. These are variable decelerations that are showing signs of transforming into late decelerations. So that's the FIGO stuff, and with just a few things lifted out that are important for you to take note of and to understand. The NICE guidelines are the guidelines that some people might be using in this country, and they are a lot more complicated. There's a lot more granularity in the NICE guidelines, and I'm not going to go through them in detail other than just to point out a few things. And again, NICE guidelines are divided into normal, suspicious, and pathological. A suspicious tracing is one whose features include one of the non-reassuring categories from down here. And a pathological tracing is one that has two non-reassuring features or one abnormal feature. Now, the second part of this table here says, what are you looking at? You're looking at the baseline, you're looking at the variability, you're looking at the decelerations and the accelerations. And each of these features may be reassuring, or they may be non-reassuring, or they may be abnormal. And there's a lot of loose talk that you will hear in terms of the way people talk about it's a non-reassuring tracing. That kind of language doesn't really help anybody because it has no reference to the actual categorization. It is a feature of the tracing that may allow you to make a diagnosis of either a normal, suspicious or pathological tracing. But itself, the term reassuring or non-reassuring is a non sequitur. And you actually need to look at these components here to ascertain whether individual components, for example, of variability, a certain threshold for a certain time, falls into a non-reassuring or not category, or whether it's frankly abnormal. Now, so there is in the NICE guidelines, there is, as there is in the FIGO guidelines, a question of time. There is a threshold and there's a time element, but they also add something else in, which is context. And as far as context is concerned, if you have an abnormality in the tracing, in the context of an abnormal pregnancy, where there's something wrong with the mother, she's got preeclampsia, or the baby's got growth restriction, that changes things, and this time element to a large extent falls away. So whereas they may have a criterion of looking at the tracing in labor and saying you require 30 minutes of whatever for something to be considered abnormal, if there's something wrong with the fetus, then you do not need to wait 30 minutes to decide that that component of the tracing is abnormal. So that is an important consideration as well, and I'll come back to it in a moment. And then as far as decelerations are concerned, they divide them into early, late, variable, and then what they call variable decelerations with concerning characteristics. And they're also concerned with the frequency that these are seen. Now, this all sounds terribly complicated, and indeed it actually really is, because to get your mind around all of this and to use it in clinical, in the context of clinical medicine is very difficult, which is why the consensus statement came out from FIGO. It's much simpler, much more user-friendly, much more the sort of thing we need to be aiming at across the board, I would say, in South Africa. So here's a FIGO table now where they talk about different kinds of decelerations, and they talk about the characteristics under which they'll be reassuring. So for example, if you have variable decelerations with no concerning characteristics for less than 90 minutes, then the tracing remains reassuring. But it becomes non-reassuring if it goes beyond 90 minutes. But if the variable decelerations have any concerning characteristics and they occur in 50% or less of contractions, then it becomes non-reassuring. Or if you have variable decelerations with concerning characteristics in more than 50% of the contractions for only 30 minutes, then it's non-reassuring. So you can see they work, there's a lot of, these are classifications that have been drawn up by a committee of experts who have been quite pedantic in the way they've set about doing it. And it's created things which are useful if you know all the detail, but if you don't know all the detail, you're really going to struggle. So just to point out what they're considered to be concerning variable decelerations, these are decelerations lasting longer than 60 seconds. If there's reduced baseline variability within the deceleration, by the way, the 60 seconds, the FIGO said 3 minutes, they said 60 seconds. Failure to return to the baseline if the deceleration is biphasic or there's no shouldering before and after the deceleration, these are characteristics of concerning variables. And as I pointed out to you, the one thing that does lapse entirely is if there is a context to the tracing, if the mother has some significant obstetric complication, such as preeclampsia, or if the fetus shows signs of any kind of growth restriction, for example, then you don't have to wait until the 30 minutes or the 90 minutes has elapsed before you call it as being abnormal. The Americans have gone for a category 1, 2, and 3. And again, I don't want to dwell on this. They have had tremendous trouble themselves trying to define what to do with, for example, a category 2 tracing, which is neither normal nor frankly abnormal. And they produced algorithms for dealing with this. And this one is by Clark. It was published in 2013 in the American Journal of Obs and Gynae. And the only thing I want to lift out here is that they emphasize that once the tracing is suspicious or category 2, that the fetal heart rate has to be reevaluated, not just once, but every 30 minutes or earlier if there's any significant change in the nature of the tracing. So, and it applies to everything that we do here. So if you're in the labor ward and you walk past the tracing, you look at it, there's some decelerations, you say, well, it's not yet suspicious, or but it's not normal either. You need to come back within a reasonable period of time. And a reasonable period of time is 30 minutes, as the Americans would define it, to reevaluate that tracing to see if your diagnosis has changed or not. Now, I also want to point out to you that there's another thing that's important, also from a legal point of view, and that is that looking at tracings at a point in time is one thing, but looking at the tracings over time is something else. And where there's been a progression from a normal to an abnormal tracing, it's highly suggestive of fetal hypoxia. And there are different ways that this has been described. Hon was one of the people who first, in the infancy of CTG monitoring, looked at patterns that evolved during labors which were complicated by fetal hypoxia, and described an evolving pattern which moved from he termed a reassuring pattern on admission to recurrent decelerations that became wider and deeper, combined with tachycardia, decrease or loss of variability, followed by terminal bradycardia. And this kind of thing is clearly associated with a risk of neurological injury to the fetus. And quite recently, in fact, I think it is this year, the Japanese have published a series where they describe exactly this R-HON reactive to HON pattern, clearly linked to the risk of basal ganglia thalamic injury, hypoxic injury in the fetuses. It's also echoed in the American College of Obstetricians and Gynecologists in their magnus opus, which has to do with neonatal encephalopathy and hypoxia. And they underline the fact that if you have a category 1 tracing, which during the course of the labor converts to a category 3, it's highly suggestive of a hypoxic ischemic event. So I can't, in the time that's available to you, go through these classifications in detail. All I can do is point to the fact that the devil does lie in the detail. And I would advise you all to choose one of these classifications and use it in your institution universally, to know that classification very thoroughly and not to get confused between the different classifications. And when you're using the classification, be rigorous in the way in which you apply it to individual patients that you'll see in the labor ward. And I would argue also it would be extremely useful if the country as a whole could standardize on one kind of interpretation of the CTG traces. And it's not helpful for people who train, for example, in Cape Town or wherever, Pretoria, and then go and work at Baragwanath to find that the teaching there is based upon ACOG rather than on FIGO or NICE, and then to have to try and come to terms with a different kind of interpretation, different process of management. I think that is actually quite significantly counterproductive. So in the last few minutes that are available to me, I want to move from monitoring to intervention. And again, whether you're dealing with a suspicious tracing or pathological tracing, you need to do something. You need to immediately take action to correct reversible causes for fetal hypoxia. And thereafter, you need to come back and evaluate the tracing again and evaluate other methods of establishing whether the baby is hypoxic or not, and if necessary, to expedite delivery. And the actions that are required, the corrective actions, are a question of lateral recumbency, putting the mother on a side, giving her tocolytic, stopping the contractions, giving her oxygen. If she's hypovolemic, giving her intravenous fluids, then reevaluating and expediting delivery. And if you're in the first stage of labor, that's going to mean a Caesar. If you're in the second stage of labor, then there is also a discussion around whether or not operative vaginal delivery is an option. Now, in addition to the things that may happen during the course of the normal labor, there are other things that can have a bearing on adverse outcome, things that may either in and of themselves cause fetal hypoxia or may aggravate fetal hypoxia. And some of these are iatrogenic factors, and here I particularly refer to the use of oxytocics and fundal pressure. And then there are things related to what the mother does and what we allow her to do, which includes the second stage of Valsalva maneuver, so the bearing down that takes place in the second stage of labor. And again, this has been addressed by FIGO, and they point out that during the second stage of labor, due to the additional effects of maternal pushing, hypoxia and acidosis may develop more rapidly. And I need to point out to you, ladies and gentlemen, that with the uterine contraction, the intrauterine pressure increases by about 40 millimeters of mercury. But when the mother pushes during a contraction, that can go up to 100 millimeters of mercury. And that has the effect of even further limiting choroidostigal perfusion of the placenta and increasing the risk of hypoxia. So in the second stage of labor, you may have a rapid evolution of hypoxia and acidosis, and urgent action should be undertaken to relieve the situation if there's evidence of an abnormal CTG. And that might include the discontinuation of maternal pushing, and if there's no improvement, delivery should be expedited. It also means, ladies and gentlemen, that if you have an abnormal tracing and you go into the second stage, be careful, because you're more than likely going to end up with severe fetal hypoxia and damage to the baby if you don't preempt that from happening. Also, FIGO, excessive uterine activity is the most frequent cause of fetal hypoxia and acidosis, can be detected using the CTG, looking for tachysystole or by palpation, and it can be reversed by reducing or stopping oxytocin, removing administered prostaglandins if possible, and or starting acute tocolysis with either salbutamol, terbutaline, ritodrine, atosiban, or nitroglycerine. Now, just to expand on this a little bit further, this comes from the Saving Babies report, and it has reference to the factors known to be the avoidable factors associated with the delivery of babies that have died stillbirths due to asphyxia, in other words, due to intrauterine hypoxia. And here you'll see in this thing here, the management of the second stage of labor prolonged with no intervention. Second stage of labor is a big problem. And it's why we increase the frequency of fetal monitoring in the second stage of labor from every half an hour, as it is in the first stage, to after every 5 minutes or after every second contraction during the second stage of labor, because it is so problematic. And there are other people who've underlined this. Here's an article from Sandstrom. It looked at a cohort of 42,000 nulliparous women and showed that the duration of pushing less than 15 minutes compared to a duration of pushing of more than 60 minutes increased the rates of acidosis from 0.57 to 1.69, nearly a threefold increase, statistically significant. So, and then the oxytocin story, again, this has been written about. The Americans have drawn attention to the risks associated with the use of oxytocin. In South Africa, it's been editorialized by amongst others, Bob Pattinson, Hein Odendahl, and Graham Houth from the MPS, and they've spoken about the risks of oxytocin in our environment. Here again, Burgott, this is right hot off the press, 2021, effective intrapartum oxytocin on neonatal encephalopathy, a systematic review and meta-analysis, split into high-income countries and low middle-income countries, and showing that there is a statistically significantly increased risk of neonatal encephalopathy whenever oxytocin gets used. And that effect is even more pronounced in low middle-income countries. So the use of oxytocic drugs carries with it the need to carry out continuous electronic fetal heart rate monitoring whilst you're using it. And if there are abnormalities, they need to be recognized timeously, and the appropriate management needs to be taken, including the withdrawal of these drugs. So what about the medical legal implications of CDG monitoring? The intrapartum injury leading to neurological evidence of injury is linked by abnormal labor. An abnormal labor leading on to early onset neonatal encephalopathy, cerebral palsy, and then eventually neuroradiological evidence of injury. And that abnormal labor, ladies and gentlemen, has to do with what we have been talking about now, abnormal fetal heart rate patterns, and in a small percentage of patients, the occurrence of a sentinel event. And a lot of this has been set out, and I would encourage everybody to go and download a copy of this. It is a bit of a Bible as far as this question of neurological injury is concerned. And it's the writings of the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics. And it's a tome called Neonatal Encephalopathy and Neurological Outcomes, second edition, reaffirmed in 2019. And this was a group of 88 experts in obstetrics and pediatrics and neuroradiology, talking about the American experience. And they work in a resourced environment where there are many things available that we don't have. And for example, there's a presumption in here that CDG tracings are going to be used in every single labor, regardless of whether it's low risk or high risk, things that we can't afford. But what they point out that there are a number of criteria that they take into consideration, which will allow the assignment of intrapartum hypoxia as the likely cause for adverse outcome in terms of neurological injury that is subsequently seen. And they say that in confirmed cases of neonatal encephalopathy, the following assessment items will determine the likelihood that an acute peripartum or intrapartum event was a contributor. And this is now what I think is important, is likelihood, probability. Many people have tried to use this document that I'm just talking about now as a sort of a tick sheet, that if you haven't ticked every block in this, as far as they're concerned, you haven't established the fact that an adverse outcome can be linked to an intrapartum event. It's not what the Americans are saying. They're saying the more ticks you have, the greater the probability that you can link it to an intrapartum event. It's not an exclusionary tick list. But what they talk about is in this document is the case definition, the neonatal signs that would allow you to define neonatal encephalopathy. Then the important stuff for us, the timing, type and timing of contributing factors, consistent with an acute peripartum or intrapartum event, and then the long-term pediatric outcome that defines an intrapartum or hypoxic injury. And again, I'm not, there's no time to go through this. I just want to show you that this type 3, this paragraph 3, type and timing of contributing factors that are consistent with an acute peripartum or intrapartum event are either sentinel events. And here they list what a sentinel event is. And it's this and nothing else, ladies and gentlemen, nothing else. And there's been a trend in South Africa to argue that a sentinel event, if it happens, is an acute, profound thing which is unavoidable, and therefore damage is unavoidable. It's not true. It's true for certain things, but for example, it's not true that an umbilical cord prolapse, if it happens in a hospital environment, it's not true that that's going to inevitably lead to an adverse outcome. If proper management is provided, the baby's going to be absolutely fine. It's not true that every ruptured uterus is unavoidable. So it's not true that every ruptured uterus is going to lead to catastrophic hypertension. So, but they are a marker nevertheless of whether or not you can pin this down as a cause for a damaged baby. And the rest of it has to do with what we've been talking about, this question of fetal heart rate monitoring patterns that are consistent with an acute peripartum or intrapartum event. So my time is almost up. Let me wrap up quickly and say, bring to your attention again that when we talk about CDG tracings, we are not talking about identifying the point at which the baby becomes injured. We are looking for evidence of an insult, a hypoxic insult, acidosis, which if it goes without intervention, is likely to lead to injury. But we only identify insult and not injury. We'll never know as obstetricians when the injury has actually taken place. And we deal in probabilities, that there's either a high probability or low probability or no probability of something actually giving rise to an adverse outcome. And I need to, working as I do now in the medical legal environment, point out to you that there are different conceptions of probability actually between lawyers and doctors. And when you talk about a probable cause for something in a legal terms, the lawyers say this is more likely than not the cause. Whereas when we talk about something in terms of probability, we are saying it's unlikely to be an event that takes place as a chance occurrence. And there's a range of probabilities from low to high. So there's a bit of linguistic difference between ourselves and the lawyers, and be careful of that if you should ever happen to be in the circumstance of talking to lawyers about these matters. But what I want to draw your attention back to is guideline adherence is what is required of all of us. And I would once again encourage everybody to pick a particular classification, to study it carefully in detail. Sit down if you want to use the figure classification. It's published online, you can get it. Take a highlighter, work your way through it, underline things, and remember what's written there. If you're going to use the NICE guideline, you probably need to carry a laminated card around in your pocket to know all the details and the exceptions that they apply to their classification. And you really have to look at the small print because that is where a great deal of what we get wrong actually resides. So with that, I'm going to say thank you very much and ask if there are any questions.
Thank you so much, Prof. That was quite comprehensive, and it is clearly evident that CTGs are not just straightforward as they appear to be. So you've made a very complicated topic very simple for us. And already there are requests, Prof, to perhaps have a session where we try interpreting or reading some CTGs. So thank you so much for that, Prof. Prof, I just wanted to ask, for guys who are running private practices, obs and gynaes, or perhaps midwives as well, would you recommend that they do NSTs in the rooms? Is there any benefit to that?
Look, I mean, I think, you know, a routine NST in a patient who doesn't have other risk factors, if they're normal fetal movements, is not really beneficial. I think the NST more plays a role if you have a problem. So if you've got a patient who's got growth restriction, for example, or who's had an antepartum hemorrhage, or is going post dates, you know, those are the circumstances under which it has some meaning. But for just, you know, sort of an otherwise low risk patient, no, I wouldn't have said that that's going to be useful.
Okay. Absolutely. Thank you, Prof. There's a few questions in the Q&A as well as in the chat. I think the one question that has been repeated twice is how long should a CTG run? This is, I'm assuming it's in labor, before you comment on it. I saw a colleague saying they run it for 20 minutes when they do the admission. Is there a time frame or a time limit?
Well, look, I mean, you know, the point is, you know, an admission CTG, for example, is something which is often being spoken about, and it probably has little defined benefit in a normal pregnancy. But where you're setting out, where you're dealing with a high-risk pregnancy, then there may be some merit to documenting fetal well-being on admission. And for the rest, the duration of the monitoring depends on circumstances. And for example, if you're going to induce labor, there is considerable variability in opinion as to what you should do. If you talk about the FIGO crowd, they will say you need to use electronic fetal monitoring throughout that labor. If you're talking about the NICE guidelines, they say once the patient starts contracting, you need to do a CTG. And once you've satisfied yourself after a period of half an hour or more that the tracing is normal, then you may resort to intermittent auscultation, providing that there's no further abnormality. And the Americans, as I said to you, there's a presumption in America throughout that nobody's going to do intermittent auscultation. They're just going to do CTGs because that's the country that they live in. That's the resources that they have available. So yes, and you know, and once the tracing becomes abnormal, or once you detect an auscultation that there is a problem, for example, if there's the fetal heart rate slows after the contraction auscultation, then you need to be using continuous electronic fetal monitoring for the rest of that labor. So there's no categorical answer to the question that got asked. It depends on the circumstance.
Okay, thank you, Prof.
Sorry, yeah, Prof, I saw a number of questions around the use of oxygen as part of either antenatal or intrapartum resuscitation. And it seems like there's some mixed, I don't know, communication. I see colleagues saying they are being told that it might lead to some dependency or even, you know, retinal injuries. Is there a role for oxygen as part of resuscitating infants from hypoxia? Yes.
Yeah, look, I mean, there's no evidence that it actually really helps, and that's what's written into the FIGO document as well. But on theoretical grounds, there's no reason not to give it. And all the oxygen is going to do is to increase the amount of oxygen that is available to the fetus by virtue of what goes into solution in the plasma. The hemoglobin is fully saturated anyway. But you have to remember that the fetal hemoglobin oxygen dissociation curve is still operating on the steep part of the curve in terms of the partial pressure of oxygen to which it is exposed. So a very small change in the partial pressure of oxygen to which it's exposed will still significantly increase the amount of oxygen picked up by that fetal hemoglobin. There's physiological reasons as to why it might make a difference, but there's no epidemiological evidence that it makes a difference. So the bottom line is give it. Nobody's saying don't give it. It's not going to cause any harm in the circumstance where you suspect there may be fetal hypoxia. Whether it causes any benefit, whether it results in any benefit, that's a separate question.
Okay, Prof. I think that is quite clear. Let's give it. The benefits probably outweigh the risks if there's hypoxia. Yeah.
And perhaps one other question, Prof. The usefulness of CTG in a patient who is not well. So it's a question by Murapedi. They're asking if there's any value in doing CTGs in a patient who's, I'm assuming a patient who's sick, and they gave an example of a patient who is in DKA. Is there any benefit or role for CTG monitoring under such circumstances?
Yeah, I mean, the question of a diabetic, for example, in diabetic ketoacidosis and the use of a CTG, I don't think, it depends on whether you think that intervention is going to be meaningful under those circumstances or safe under those circumstances. And I think that is one particular situation where the focus is pretty much going to be on the mother and not on the child. It's a question of treating the mother first. And then once you're reasonably sure that you're getting on top of the ketoacidosis, then that's the time to introduce the monitoring. It's the same with a patient who comes in with eclampsia. The immediate concern is not to establish whether there's fetal well-being. The immediate concern is to treat the mother and to make sure that she doesn't come to any further harm. So the mother's interest is always going to trump that of the fetus. But at a particular point where you've got control over the maternal risk, you need to then start paying attention to the fetus. It's not the first priority when there's a mother that's sick.
Thank you, Prof. And Prof, your opinion on meconium stained liquor, intrapartum? Should we be doing scissors in the early latent phase if we identify meconium stained liquor? Is there any value to using it, to assess fetal well-being?
Okay, so I mean, there are two things here. Firstly, an absence of meconium stained liquor, in other words, seeing clear liquor, does not preclude fetal hypoxia. That's the first thing. You can't use it to say because the liquor is clear, there's no hypoxia. Secondly, the question of meconium, if it's present, it may be present for any number of reasons, as you know. And there's a difference between thin and thick meconium. And I need to say as well, this question, we've got into the habit in this country of grading meconium, grade 1, 2, and 3. Well, you go and find any international literature that substantiates the difference between grade 1, 2, and 3. It doesn't exist. So what we need to focus on, which is what's in the guidelines, the South African maternity care guidelines, way back to 2007 even, between thin and thick meconium. And if there's thick meconium, it's more likely to be associated with fetal hypoxia, especially when they're coincidental fetal heart rate abnormalities. And the finding of thick meconium equals the need for more monitoring. It doesn't equal, let's do a cesarean section. Meconium is not an indication for cesarean delivery.
Awesome. Thank you, Prof. I don't know if you've seen any further.
Prof, I saw a number of comments around, because you've mentioned that the CTGs are more sensitive than specific. So there's questions to say, is there a need to then have a confirmation of some sort? Is there a place for testing for acidity? What's your take on that?
So, well, I mean, again, if you go back to the European criteria for the use of CTG monitoring, they always talk about adjuvant testing. And the adjuvant testing, which has gone by the board in this country during labor, is fetal scalp blood sampling and looking at the fetal pH. And we don't do that because of the prevalence of HIV in our community. And because we're never going to be 100% certain of the woman who comes in labor, even if she's on treatment, what her viral load is going to be at that stage. So we don't do that. And we have to deal in uncertainty and probability when we use CTGs to look after our patients. That's the way it is. That's all there is to it. And we've got to give the baby the benefit of the doubt. if the tracing may be indicative of a high probability of fetal hypoxia. And there's nothing else we can do that's going to provide us with the kind of answers that we need. And in any event, I mean, the technology is very robust. And as I said in my talk, and as you've been alluding to, the sensitivity is actually very high. There's no doubt about the fact that it tells you if the baby's hypoxic, tracing will be abnormal.
So, Prof, okay, I'm not working in the space, but I'm trying to figure out. But I think you have answered it to say, one, you look at the trace. You also have to look at maybe the context, which is how the mom and the fetus are doing. Because I'm trying to think when it gets to the legal space, is there consideration that I mean, do we have, because the sensitivity is so high, naturally it would mean that we are not necessarily acting on all traces, right? I just want to understand at what point in the legal system is there consideration that there's always a probability that we might not act even when the trace is abnormal. Is that an understanding as well on the legal side?
Look, I mean, the legal side is really a separate talk on its own almost. But what needs to be said about this is that in South Africa, there's a great deal of litigation, obviously, against the state and against private practitioners. And private practitioners are paying, you probably know better than I do, more than R1 million a year for medical indemnity in case they get sued. And the reason they're getting sued is because of abnormal CDGs and an adverse outcome. So, and you know, again, I only see one end of the spectrum, obviously, but those that I see, there's nothing subtle about the question of mistakes having been made, either because monitoring has not been done, and indeed, it's actually no different to the stuff that's been published in the Saving Babies report. The things that Bob Pattinson and the others who've been involved in those publications have highlighted. That's what you see in terms of it's there. It's the same stuff. Either monitoring not done, or fetal distress not detected, or detected but no appropriate action taken. It's the same stuff. It's not subtle.
No, thanks, Prof, because I saw another comment. There's a colleague who's watching this and he's on duty, and he's saying he's observing 20 pregnant women and with one medical officer, and they are not sure how they are going to have time to review all the traces, you know. So that context as well, I think it needs to come in. But I think the reports are very clear that there's obvious basic things we need to be doing, you know, and where we do them, we are not even acting when things look abnormal. But yeah, it's quite a dynamic environment.
I mean, I think there are challenges on both sides. There's a challenge in the public sector in terms of resources and the number of patients that need to be looked after. But actually, in a strange kind of way, that same challenge exists in the private sector. Because in the private sector, what happens is that women generally want to be seen and delivered by their gynae. And you know, their gynae needs to be available all hours of the day and night to do this. And the gynaes can't do this. So the gynaes go to bed at night and they leave the care of the patient in the hands of private midwives. And when things go the wrong way, they haven't been there. They haven't observed. They haven't had the input that they need to give in terms of their professional training and experience and judgment to the situation as it begins to go awry. And it is the same thing. There's not enough cover. So to fix this, I don't know how you fix this. And I think we need to, what you're doing is the right thing. We need to have more outreach training. We need to up the level of skill amongst the midwifery staff. We need to up the level of skill amongst the doctors in general. And I feel very sorry for especially the Cosmo doctors that end up sitting in small peripheral hospitals trying to make the best that they can of a situation which is often quite difficult. So I completely acknowledge that, and I think you know it's a task for this country going forward is how to better resource the healthcare system all around and to deliver a better service, because we do need to do better than what we're doing at the moment.
Yeah, Dr. Billy, very challenging.
Yeah, indeed. I don't see any further other questions or comments on the chat as well as on the Q&A. So I'd like to appreciate you, Prof, for your time and very informative talk. You've really highlighted the importance of us monitoring these fetuses in the intrapartum period, as well as antenatally. So thank you so much, Prof. We are going to really use that and put it into good use as we see our patients. Thank you, Prof.
It's a pleasure and good luck going forward.